So independent, patients doing everything, no supervision, no verbal cues. Modified independent is an assistance level that is not necessarily used in every facility. So for example, if you end up working in a inpatient rehab facility, which is a step of an acuity between the hospital and a nursing home, patients that go to inpatient rehab, for example, Encompass Health, which used to be known as HealthSouth, that's a type of inpatient rehab. These patients are deemed able to tolerate 3 hours of physical therapy a day. They have to tolerate at least 3 hours of therapy a day to go, or physical occupational speech therapy to go. And modified independent is a level that is oftentimes used in that setting. It's not necessarily used in other settings. Some settings it is, but not all. So what that means, a modified independent, is that the patient is doing 100% of everything themselves, no supervision, no cues, but that they're using an assistive device. So anytime they need something to help them, whether it is a bed rail to get out of bed, a walker, a cane, whatever, they're using it independently, but they still need that device. Supervision, they either need supervision for safety or verbal cues for safety. So I'm not touching them, but I need to be there, or I feel I need to be there for them for safety. Contact guard assist, this is typically what we kind of call steadying assist. So the patient's a little bit unsteady. I don't really actually do any of the work, but I do physically touch them. So they're walking, maybe I can put my hand on their shoulder, their hip, the gait belt, and it's just to help steady them, but I'm not like pulling up on them at all. Handheld assist is an assistance level that you don't always see being used. It's kind of facility and therapist dependent, and that's really good for people who maybe are just a little bit unbalanced, and instead of controlling them centrally, we're directing them distally by holding their hand. So maybe they are working, let's say, on balance by navigating through cones. Instead of me really controlling at their hips or holding on a gait belt, I'm just offering my hand to help steady them through the cone course. We then have minimal assistance. Minimal assistance that the patient is doing 75% of the work. We as the caregivers are doing about 25%, moderate, 50-50 split. And then maximum assistance is the patient does about 25% of the work, and we do the other 75%. Now, these are obviously not something we can actually physically quantify easy. And I will say that students, especially in your first year, but even in your second year, have a hard time a lot of times understanding the difference between min, mod, and max, which makes it hard to practice because you're the patients for one another. However, once you go out into clinic and you actually work with a lot of different patients, it's much easier to understand. So for example, Cameron, you work as a nurse, you probably have a good understanding what a min assist patient versus a max assist patient is. Those two are a little bit easier to understand as students. So for example, if you're helping your patient get out of the, off the bed and into the chair, and they're kind of just like this and making you do all the, like most of the work, you're probably close to a max assist, versus if you just feel like you're pulling up on them, but they're doing a lot of the work, that might be more of a min assist. But really try to, as the patient, mimic this as much as possible. Granted, I know it's hard because you don't have the experience with it, for one another to get a feel for that. And then dependent or total assistance means that the patient is not doing anything, we are doing all of the work. So we're 100%. Now, I will say that anytime you need two or more caregivers, regardless of the assistance level, it should be labeled as total or dependent. However, you should quantify what it means. So for example, if I have min assist of 1 and max assist of 1, I would put that in there, but it's still a total assistance. Because when we look at that assistance level, we're deeming kind of how much care that patient needs. And for the example of inpatient rehab, that's how reimbursement for that patient's, part of the reimbursement for that patient's stay is based off their assistance level. So if you need 2 caregivers, it needs to be a higher level of assistance to get that higher reimbursement because you're paying for 2 people to take care of them essentially. But if you're using a total or dependent assistance because there's 2 people, you should quantify how much each person is doing. Yep. So, close supervision is going to be a little bit different than regular supervision, and again, it's not a level that's always used in every setting with every therapist. With close supervision, it's saying, I'm not going to touch you, but I'm not going to stand back here and watch you do it. I'm going to stand close so that if you go to fall, I can grab you really quickly because I don't quite feel comfortable standing back here and saying, okay, show me how you're going to do it. Oh, be careful, you know, reach for this or whatever. And then standby assistance is kind of like close supervision, kind of like contact guard. This is the problem with those, is they kind of like start blurring the lines and going on one another. So standby assistance, close supervision, similar, working into contact guard. I'm close, my hands kind of hovering, and I might or might not be touching the person. But, so really above here, no touching, below, touching. Okay? So when we start thinking about documentation, we have to be able to document what exactly we're doing with our patient. So maybe we're doing supine to sit through sideline, so like rolling onto our side, pushing up. We get into sitting, and we do let's say a stand pivot transfer into the wheelchair. So we're going to document supine to sit, how much assistance. We do a stand pivot transfer, how much assistance to the wheelchair. Did they use an assistive device? All of that information has to be documented in, and I can show you some examples of that as we go through things. Okay? So, in the back of our mind, these are always there. We need to understand these, know them in and out, because they're going to be a part of your life as a therapist forever with every task that you do. Okay? Alrighty. Can I have a patient, please? I don't care who it is, but can somebody come on up? Go ahead and lay down for me. Alright, so I'm just going to go through some different transfers. I will go through a variety of them, and then I will give you some time to practice and come around and just kind of cue you. The other thing is I'm recording this, so I'll post this video so you can use it to practice as well. So we're going to go from supine into the wheelchair, and I'll try to like say things out loud that I expect as we go through. So anytime that we're going to be getting somebody up, before we actually start moving them, we want to think about setting up our space and making the space safe as possible. So let's say she had like a garbage can here that she was just kind of throwing tissues at, and there's tissues all over the floor. Clean those up, get them out of the way. She has a bedside table, out of the way. If I know that I'm going to be getting her up into a wheelchair or a chair, I need to have that close by. If I'm going to be getting her out of bed, I need a gait belt, have that close by. While it is important that we always have brakes on the wheelchair when we're getting a patient in and out of a wheelchair, don't put the brakes on whenever you are setting up the space so that you can move it where you need to easily. In some of the videos on the publisher's website, they just show the leg rests being pushed out of the way. I recommend just taking them off, getting them out of the way so that regardless of where you move the wheelchair, you're not fumbling around with them. Just get them out of the way. You don't want to be stepping over leg rests. It increases fall risk. You never leave the leg rest on in place whenever you get somebody up and out of bed. If you're going to be using, for example, a walker for the transfer, have the walker nearby. Okay, so always just set up first. And then you can also start to think about the patient scenario and which way you're going to get them out of bed. So for example, I don't know if we talked about this, but we always try to transfer towards the patient's strong side. So if I, in my head, am thinking, okay, if she sits up right now and she transfers that way, that would be indicating that her left leg is the strong leg. If she sits up and she goes that way, but the right leg is the strong leg, she would be transferring to the weak side. So in that case, before I even get her up, I want to just bring the wheelchair here so that when I get up, I'm automatically going to the strong side. Okay? I'm going to just put it over here, and we're going to say that her left leg is the strong leg. The other thing, if you notice, you may not have noticed, but on your wheelchair, if you look at the wheels here, in this position, the wheels are sticking out pretty far. They can be in the way to the side here, but if you get it just right, get the larger part behind, then they're not in the way. So just kind of always think about where your wheels are, and are my patient's feet going to get stuck in them. All right, so we're going to get up and get out of bed. What I'm going to have you do is turn your head to the side, reach your arm across your body. We're going to lift this knee up. On the count of 3, we're going to roll over. 1, 2, 3. From here, you're going to push with this hand and that elbow. I'm going to help you with your feet and your trunk. 1, 2, 3, and sit up. No dizziness. Okay, we're going to get out of bed and into the chair. In order to increase safety, I'd like to put this gait belt around your waist. Is that okay? Okay. The teeth are going to go towards the middle, facing out. I want to make sure that I don't have any twists in my belt. This is going to go on pretty snug, but as you stand up, it'll feel a little bit looser. Anything extra on the gait belt, I can just bring around and tuck. I want to make sure that it is snug. I do need to be able to get my fingers underneath there, but that's pretty much all the room that I need. All right, so what I'm going to do is show you a stand pivot transfer first. And with the stand pivot transfer, we can leave both armrests on the wheelchair because they're going to be standing all the way up. I'm still going to want the wheelchair to be pretty close. I don't necessarily have to have it as close as I do for some of the other transfers because they're going to stand up. But I don't want it to be far away. I want to limit the space that the distance that the patient has to travel. Because, for example, if I get them standing up and all of a sudden they go to pass out, I don't want to have this big gap in a potential area for the patient to fall. So what we're going to do is we're going to scoot forward. You're going to keep your feet flat on the floor, push from the bed, leaning forward, nose over toes. We'll come to a complete stand, pivot our feet. You'll step back to the chair till you feel it on the back of your legs, reach back and sit down. Okay, so scooch forward, keep those feet back and flat. You're going to push. I'm coming under her arms. I never want to go over her arms. For example, if she was going to be standing up and going for a walker, and my arms are like this, all of a sudden I'm in the way. I don't have as good of control. I'm going to be straddling her and making sure I have good body mechanics. And I always do an underhand grip on your gait belt. All right, 1, 2, 3, stand up. We're going to turn, reach back, and slowly sit down. Okay? Now, when we turned there, her left leg was the strong leg. If I go to get her back in bed, leaving the wheelchair here, we're going towards the weak side. Now, we typically always want to go to the strong side because it increases our success rate, essentially. It's easier to pivot on your strong leg. However, there's not always instances where the patient can always go to the strong side. So it is important for us to train to the weak side, but usually we start with going to the strong side to increase their confidence, to make sure they know what they're doing, and then we start going to the weak side. However, if I was not at that point and I wanted to get her back in bed, hold your toes up for me. I would simply just bring the wheelchair around and repeat the process. So scooch out to the edge of the chair for me. You're going to push off, leaning forward, nose over toes. Come to a complete stand. 1, 2, 3. Stand up, turn till you feel the chair. Reach back and sit down. If I was going to get her laying down, I would take the gait belt off before I have her lay down. Okay? So that's a stand pivot. The next one I'm going to show you is the scoot pivot or squat pivot. With this one, our patient is not coming to a full stand. Because they're staying in that squatting position, and their butt's going to be sticking out, we do need to remove the armrest that is closest to them. and just get it out of the way. You also are going to put your chair at a 30 to 45-degree angle to the bed so that they can swing into it, but that it's not too far away. And you're going to have your patient scooch forward and turn their feet in the direction that they're going. So face their feet away. When we do a squat pivot, or when we do a manual dependent transfer, we have to start thinking about the head-hip relationship. And basically what that says is that your butt is going to go opposite of your head. So if you think about taking your head this way, which way does your butt go? That way. So if I want your butt in that chair, I want your head this way. We want our patients to do as much as possible. We want to encourage them to assist us. So we would want to tell them to push off of the chair, to reach for the opposite armrest, or push off the mat and reach for it. There are times though that the patient does not necessarily feel comfortable with that. Their arms will go crazy. Never, ever, ever let them put their arms on your shoulders. They will end up around your neck and you'll increase your risk of injury. They can put their hands on your forearms or around your waist, but never shoulders or neck. Okay? But ultimately you want to encourage them to use their hands as much as possible. So I'm going to get in here nice and close. You're going to push from here. You can push from the edge of the chair if you want. And as we swing around, if you want to grab for that, your head is going to look over my shoulder. And on the count of 3, 1, 2, 3, and transfer into the chair. So we're not coming to a full stand. It's a pretty quick pivot. And again, if I was transferring her back into bed to stay on the strong side, I'm just going to move the wheelchair around and have this one back. This guy out of the way. All right, you're going to scooch forward and face your feet that way. Push from the chair, push from the bed, head goes this way. On the count of 3, 1, 2, 3, go. Okay? We can keep the same setup if we are using a transfer board. And did you look at various different types of transfer boards that we have here? Okay, so we have wooden, we have like a plasticky type of material one. As you can see, these are pretty beat up, so the more beat up they are, the less, or the more friction that they have, which their whole goal is to decrease friction. So one of the ways we can get around that is by putting like a towel or a pillowcase on this, and that decreases the friction as the person moves across it. And you especially want to do that like if they're only in a hospital gown, you don't want to get blisters in your hind end, but it feels good. Some have holes, some do not. Some are super long, some are short. So you need to find the right board that works for your patient, for the distance that they're traveling. And the thing with these is we never, ever, ever want to let our patient curl their fingers over the end or around the holes. So as they move over the board, they will squash their fingers. So we also always want to make sure we get at least one butt cheek under it whenever we start the transfer. So we're going to be using this to transfer into the chair. What I'm going to have you do is you're going to lean away, get it underneath, and I actually want to move my chair closer, so I want to make sure I'm spanning the gap. You are going to be pushing with your arms, and you're just going to slide your bottom across. It does not have to go all at once. We can do a series of small steps if we need to. Turn your feet this way to make it a little bit easier. 1, 2, 3, 1, 2, 3, and one more. Good. Now lean this way for me, and we'll take it out. We can also encourage our patients to do it on their own. So what you're going to do is you're going to grab a hold here, lean over, put it underneath you. You never want to keep your hands under. You can put them on top or on the table as you transfer over. Go ahead. Good. And then I can just direct them. And this would be more of a contact guard assistance versus me physically helping them. They're very helpful for individuals, let's say, that have bilateral lower extremity issues. So for example, if you had somebody that fell off the ladder hanging their Christmas lights and they broke both their ankles, they cannot stand or they cannot do a squat pivot because they are non-weight bearing on both their legs, this would be great. Maybe somebody who has had a spinal cord injury that still has good use of their arms, but does not have sensation or movement in their lower extremity. I've also used these with individuals who are just really weak because they've spent a long time in the ICU and they do not feel safe, or they spent a long time, whatever, very deconditioned, they don't feel safe standing, they're very shaky standing, maybe they need assistance of 2 people, but I'm the only one that can help them at that time. I can increase my safety by having them just slide over on the board. So sometimes we use it just as like a training, let's get moving sort of tool. Sometimes we're encouraging patients to use these long term. So for example, maybe someone who has a spinal cord injury who's not going to be able to walk again in the future, that they can use that long term. Okay? We can also use this same setup when we do the manual dependent transfers. So essentially a manual dependent transfer is a squat pivot transfer, but that we are doing all the work. So we don't want to have we still want to encourage our patients to help us, but it's going to be us doing most of the work. This is very hard as students usually to kind of give up that control and let your partner move you, but it's extremely important that you do practice it this way, so that when you actually have a patient in the future who has maybe other ailments like a broken arm or a broken leg or something, you have some experience with it. So we're going to do the same setup. We're going to remove the armrest to the side that we're transferring to. Chair nice and close. Body mechanics are extremely important when we're talking about dependent transfers because it's very easy to hurt your back. If you do this correctly, you will offset your partner's weight by moving your own body, like you'll lean back, which will pick them up. We should never see somebody who's bending at the elbows to pick somebody up. I will tell you, early on in my career, I was pretty strong and I would just muscle through transfers. By the end of the day, muscling through transfers, my arms hurt, my back hurt, it was not sustainable. You have to learn to use your body correctly. And it significantly decreases the risk of injury for you and your patient if you do it correctly. So, wheelchair nice and close. We're going to scooch to the edge, and because your patient is requiring a dependent assist, don't do anything, let me help you. I'm going to move her feet out of the way here. I'm going to make sure the wheels are out of my way. All right. You either can keep your hands at your side or you can put them on my waist, okay? We're going to put your head over to the shoulder. I'm going to squeeze her knees between my knees. That's going to create a nice pivot point for me. All right, do not help me. 1, 2, 3, lean. Get back over there. Stood up. I'm not going to count because then she's going to help. So I'm just going to lean back, pivot, sit. Okay? And so just go back. You're going to have turn your feet, squeeze your knees, tilt you this way, and I would count normally, but I'm not going to. And I'm just going to lean back, pivot. Because I have her knees between mine, her feet can't go anywhere. We can put the person in a non-weight bearing position though. So, for example, if I have somebody who, variety of reasons, maybe they have fractures or something and they're non-weight bearing, if they have wounds on their feet, if they're, for example, I've had patients with spinal cord injury that have a lot of spasticity, and so when you go to move them, their legs kind of kick into extension or whatever. This is really helpful for that because you have more control. It is a little bit harder because you are the only pivot point at this point because their feet are not on the floor. And I'm sure you're going to love this since you love giving it control. Okay, so I'm going to get them in the same position, but I'm going to lift her feet up off the ground. So now I have to do all the work. 1, 2, 3. And so I just lean back and then I put her feet down once I get it over. So I highly recommend that you practice it both ways. Because when the patient's feet are on the floor, they'll still try to help you, but when they're off the floor, you're stuck doing it. And you'll really realize how much you need to lean back. So one of the things I always kind of recommend to people don't start by just doing the transfer. Just start by leaning back and just seeing like what point you need to be at. I'm not taping my face mask. But just start by leaning back to see what point you need to be at to kind of balance your weight versus their weight. Okay, so we have standing pivot, squat pivot, transfer, board, manual dependent. Another thing I wanted to address is if we're using an assisted device, we're going to be doing a stand pivot transfer. Because we're using the assisted device, we still want the wheelchair to be close to the bed, because if it's far from the bed, then we're actually just walking with the patient and not transferring. But it doesn't have to be as close because you need to leave room for the device. So if I have her set up this way, I'm assuming then that her left leg is her strong leg, because I'm going to be on this side, which is her weak side. When we use something like a walker, we don't want to be in front of the patient because then we're just getting in the way of the walker and it's not safe. So we're going to do the same sort of thing. You're going to scooch forward. Now, we never want to pull on a walker because it will tip. You'll go backwards. If you're in the right kind of chair, everything will go backwards. So you're going to push from the chair with both hands. I'm going to stand kind of behind and to the side. Hand on the gait belt. My other hand is going to be on the front of her shoulder here. I may, if the person needs more assistance, be on both sides of the gait belt, but I never want to be like this, because as she goes for the walker, I'm in her way. So you're going to lean forward, nose over toes, and on the count of 3, we're going to stand. Once you're standing, you'll grab the walker. 1, 2, 3. Now grab the walker, okay? Now you're going to pivot to the bed. So you feel the chair on the back of your feet. Reach back. Do not hold on to the walker as you sit down. So when they stand, they do not pull on the walker. When they sit, they do not hold on to the walker. They only have the walker when they're standing. So push, reach back. Okay? Are those the majority of the transfers that you worked on? Okay. So go ahead, get with your partner, take some time to review stand pivot and stand pivot with a walker as well. Squat pivot, transfer board, and a dependent transfer. Oh, really good point that I forgot to, that just reminded me. When you use the transfer board, you want to make the surfaces as level as possible. However, it's not always possible. Like sometimes they will have to go uphill or downhill on a transfer board, but making them as level as possible is the most ideal.
I have a question about this. So when you were here, she said that we could take the belt and like loop it back through like the excess that we have.
No.
Do you not like that?
What do you mean? Like put it
I
on?
can show you. So she said like we could take it through here and then back around.
You can. The only problem is if you accidentally pull this,
Okay.
you've just taken the, like it will fall off. That's why you always just go around the opposite
So
way.
for the for the competency, would you rather just go?
I would,
Okay.
and I would just say it's probably a better habit to get into, only because if your patient goes to fall and you just go to grab the gait belt and that's what you grab,
Yeah.
like you could potentially just unravel on the belt. So.
Alright, thank you.
Yeah. All right, so we're going to start talking about gait training today. We'll start looking at some assistive devices, practicing some different things, and then we'll finish up next week, whatever we don't get done today. So just like we have assistance levels when we start talking about transfers, we still think of assistance when we do gait training, but now we also have to think about weight bearing and weight bearing restrictions. And so we have a couple different weight bearings that we need to be aware of. So NWB is non-weight bearing. This is 0%, 0 pounds, no weight at all. That does not mean that they can touch their heel down, their toe down, nothing. Foot up off the floor, no weight through the area or hand. non-weight bearing is important, especially after somebody has had an injury or a surgery, because it helps to take stress off that area during the initial healing process. So if we start putting stress and strain through the area by placing weight through it, we can actually disrupt that healing process. So if you see non-weight bearing, nothing. That does not mean that if the patient starts walking, that you have them walk, let's say with a walker, and that they put their foot down on the floor, that you say to them, oh, pick your foot up, and you just keep letting them do that step after step where you say, keep your foot up, keep your foot up. No, you stop, you sit them down, you re-educate what non-weight bearing means. If they are not able to or if they're not able to continue it at a non-weight bearing, you do not continue with what you were doing. Okay, so non-weight bearing is non-weight bearing. We then have toe touch weight bearing, TTWB. Toe touch, sometimes you'll see TD, touch down weight bearing. Toe touch weight bearing is just a toe. So essentially their toes, I guess we can say toes, are there for steadying assist, but they should not be placing any real considerable amount of weight. So they can just put their toes down. Sometimes it'll say toe touch weight bearing, but then it'll be modified that it is heel weight bearing. So for example, if they had an injury at the towards their toes, they might be allowed to just put their heel down. But really no weight, it's just to steady them. We then have partial weight bearing. Partial weight bearing is always going to have some sort of percentage of body weight attached to it. It's generally 25 or 50, but it is going to be dependent on the patient, the injury, and the doctor that prescribes it. So for example, if somebody had a surgery and they're allowed 25% weight bearing, or maybe they're 50, or maybe they start 25 and they progress to 50 after a couple weeks. So in order to figure out partial weight bearing, you have to do a little bit of math. So if you have somebody, let's say is 120 pounds, if they're 50% weight bearing, that means they're allowed to put 60 pounds through that foot. An easy way to educate your patients on how much they are allowed to put is just having a regular bathroom scale. And usually we have, if you have like a little platform that will put them, their other foot at about the same height, you'll have them standing, straddling the scale with their involved lower extremity on it. And so let's say it's 60, have them put most of their weight on their good foot, and then practice weight shifting over to where they hit 60 pounds, and that will give them a good idea of what 50% feels like. And so this is a really good initial activity. Obviously they would have support on their hands. And then that way they can see, oh, I'm at 70 pounds, that's too much, I need to back off. Do this before they even start doing any mobility tasks like walking or transfers or anything, so that they can ensure, or they have at least a general feeling of how much they're allowed to put. So if you have a partial weight bearing, you need to understand what percentage they're allowed and then figure out their body weight and then have your patient go from there. Again, we never want to just assume that they're putting 50% or 25%. We never want to let them continue walking if they're demonstrating that they are not. So for example, if they're walking along and they let go of their walker, like maybe they're talking and they stop and they're not holding on their walker, and they're like not putting most of their weight on their good foot, you know they're not maintaining that. You got to sit back down. Some clinics may have limb load monitors, which are basically little like scales you can put on the person's shoe. They're expensive, they're used mostly for research, but you may find them in clinic. Those are really great ways because you can actually see it as the person's walking. But we then have weight bearing as tolerated. And this is the amount of weight that the patient can tolerate. It's their own decision. So they may say, because of pain, not put any weight on. They may self-select to be non-weight bearing, they may self-select to be toe touch weight bearing, they may select to be 50%, they may select to be full weight bearing. It doesn't matter. The amount of weight that they put through it is not going to injure anything. They are the ones that have to choose how much. So for example, if somebody has had a hip replacement, oftentimes they come out of the OR as weight bearing is tolerated. And that means that if they can tolerate putting full weight, you know, first time they get up out of bed walking, great. If they're really having a lot of pain and they just choose to not put full weight, that's fine too. And then we have full weight bearing, which they can put 100% of their weight through that arm or leg. So they can stand on the extremity. So we think about weight bearing restrictions for legs, specifically when we're talking about walking, but arms can also have weight bearing restrictions. So if my patient is a non-weight bearing in an upper extremity, I can't use something like a walker, crutch, or cane. I can't have them leaning on their arm as they're sitting, so they need to be non-weight bearing. So you have to think about it that way. Anytime we have a non-weight bearing lower extremity, we have to use a two-handed device. So if they're non-weight bearing or toe touch weight bearing or even partial weight bearing, we would never put them on a cane. If they're non-weight bearing, toe touch weight bearing, partial weight bearing, walkers, crutches, we have various types of walkers and crutches over there. Those would be appropriate because they have to offset that weight. Any questions with those? So, need to know them, need to understand them, need to be able to instruct your patients on them, as well as know when your patients are not adhering to them and how to get them to make changes. It is never okay to keep walking and just saying, you need to be 50%, you need to be 50%, or you need to be non-weight bearing. You stop, re-educate, readdress as needed, have them sit down. Don't just keep walking down the hall and allow them to be weight bearing if they're not supposed to be. So moving from weight bearing status, we then have to think about assisted devices. We have a lot of different assisted devices that we can choose from. When choosing an assisted device, you have to take several things into consideration. The patient's prior level of function is really important. So if they used a walker before they came to the hospital and you're seeing them, should you have them use a walker now? Yeah, if they used one before, it's a good idea to start using one now because if anything, they're worse off now if they're coming to see you in a hospital. But let's say somebody was independent before, they still may need a cane or a walker or something depending on what's going on. So their prior level of status or prior level of function is going to be important. You need to understand what they were able to do beforehand because chances are they're still going to need that device now. Is age important to understand when you're choosing an assisted device? Why? You're shaking yes. Can you give me an example of what you might?
Well, like if you have an 80-year-old patient, they would probably, chances are they need a walker more than just a cane.
Okay. I'm going to say no. Age does have some relevance in getting you thinking about what they might need. However, I have put an 80-year-old on crutches and I have put a 19-year-old on a walker. It's going to be based off their prior experience and how they're currently functioning. So I had a 19-year-old who had a pelvic fracture, who I thought 19 years old, she's probably played on crutches before. I knew she had never been on them. But it's not going to be, like 19-year-olds can get on crutches. They're pretty mobile, right? Horrible. Absolutely horrible. She was going to fall and hurt herself and break more bones by being on crutches. So I said, you know what? Let's get a walker. It's going to be safer for you. Much safer. I have had 80-year-olds, well, probably not 80, 70-year-olds, who I go to give them a walker, and they're like, I've never used a walker before, but I have used crutches multiple times, including last year. Okay, let's assess, and let me put you on crutches. So while we kind of start thinking about age whenever we see our patient's age and their diagnoses, we can't rely on age to tell us exactly. So don't let that kind of cloud your judgment of what a patient can and can't do. Their current functional level is going to be important. So if they're a maximum assistance, am I giving them a cane and sending them on their way? No, not going to be safe. Their weight-bearing status, diagnosis, if they have pain. Cognitive level is a big one. So if somebody is really confused, you have to take that into consideration. Sometimes assistive devices can actually increase your fall risk if their patient is not safe with using them. So if they're not safe because they're confused, then you need to think about maybe a different device that would be easier for them to use or something that they've used in the past. So just taking into mind that. And then whether they can use both legs or whether they can use both arms. So if they have, let's say, a humeral fracture, am I giving them a walker to use? No, because they would need to have both hands to do so. All right, what I'm going to have you do now is we're going to go back. We're going to look at some of the different assist devices, talk a little bit about them. I'll talk a little bit about them, and then we're going to do a little activity with them. So let's go on to the back of the room here. So before we get started in these assistive devices, I'm just going to prop this here. Whoop. Over in that corner of the room, we have the parallel bars. Parallel bars are considered an assistive device. They're obviously very stable. However, are they functional? Can we take them throughout life with us?
No.
No. So they're wonderful training devices, but they don't have the ability to go different places with us, so they're not as functional. Let's see. I'm just going to pick random things. So this is a rollator walker. We have two different ones here. Someone busted that seat up. Rollator walkers are kind of like the Cadillacs of walkers. Fun colors score you extra points at the senior center. Fun accessories also score you extra points. These have their purpose. However, they also have their downsides. So they have 4 wheels, which makes them roll very nicely, especially over things like grass and gravel. However, it also makes them roll very nicely. So if I have a fall risk, a patient with a significant fall risk, I'm going to say, let's not use this. The nice thing that they are used for is if somebody just needs a little bit of steadying assistance, but let's say doesn't have a history of falls, or if somebody has impaired endurance. So if I know I need to get all the way through Walmart to get to the back to go pick something up back there, but I need a seat partway through. Oh, I have a seat with me. They do have brakes. However, brakes aren't really that great. So brakes are meant to be used kind of to keep it partially steady. But if I'm going to be using this to sit on, I really should put it against a solid surface before I sit down on it. They're also very handy because it's kind of like having a shopping cart with you, sort of. You can, for instance, if I'm on oxygen, I can put my oxygen on here. I can hook it on here. They do come with all sorts of baskets and things. So they have their uses. They also have their downfalls. This is a quad cane. We have a variety of different examples of quad cane here. So we have a narrow base versus a wide base quad cane, and that's just talking about the bottom. One-handed device, a little bit steady as long as all 4 feet are on the ground. You will see people kind of like rocking it as they walk, which takes away some of its stability. When you are working with a quad cane, the important thing is that the flat side of the feet is towards your feet. So see the difference here? So if I were to turn these this way, I'm going to kick these. So I want to put the flat side. Now, that doesn't mean that I have to look through all the canes to find the right one for my patient, because they can just be, if I can get it to work, broke this. There we go. you can just turn it so it's the other way, okay? So you always want to hold on with it facing backwards, but if I need to, let's say, use it in this hand, I would just turn the feet. Okay? A variety of quad canes. This is a Hemi walker. So it has some of the nice properties of a walker, like a wide base of support, but it's only for one upper extremity. You also would have this position so the flatter side is towards the patient's feet. So you would never want to do it like this, because again, they're likely to trip over it. Also, really only stable if all 4 feet are on the ground. These are very helpful for individuals who are not able to use one upper extremity but need extra support. So for example, if I've had somebody who's had a stroke that affected one side of their body, these can be very helpful. They also, because of their size and that they're one-handed, they can also be very clumsy for people. So I'm generally very cautious as to who I use a Hemi walker for, but it certainly is very helpful, especially in the CVA population. We also have straight canes or single point canes. We have a variety of different ones here. So wood canes, you will see people use wood canes. Wood canes are wonderful as long as they have a very nice rubber tip on the bottom. Without it, they're very slippery. And that they are the right size for the patient. I can't tell you how many times I go in to see patients in their home, and they're these wonderful little old ladies who are like 4 foot nothing, using their deceased husband who was 6'10" cane, and they're walking around like this. Not sizable unless you cut it off, so that's the downfall of them, but people love their canes. We can also have an offset handle versus a regular one. This handle ends up, because the positioning of it ends up distributing the weight directly down, versus this one, your weight is slightly posterior to the base of the cane. So it doesn't make a huge difference, but if somebody is a little bit more unsteady, this actually feels steadier in your hands. You can feel the difference when you're messing around with them. Again, height adjustable. Some people, it's just patient preference. All right, we have crutches. How many of you have ever used crutches? How many of you have ever played around on crutches? Okay, good. It always astonishes me, like, the number of people who have never did anything with crutches. Crutches can be used bilaterally or unilaterally, so 1 or 2. Same thing goes specifically with the single point canes. You could technically use 2 quad canes. I wouldn't recommend it, but you could. Important things with these is that you never want them to be too high up in the armpit, because you can actually have nerve damage pretty easily. So fit is really important with any device, but specifically with these. They have aluminum ones. There are still some wood ones around. The aluminum ones are lighter, which is nice, and oftentimes they're easier to adjust. They also make some newer ones that kind of have this shape versus a traditional, except they're just bigger, obviously, and have a handle for your hands. They're very nice. Insurance typically doesn't cover them, but they are wonderful. So regular crutches or axillary crutches. These, we have some examples of loft strand crutches. Loft strand crutches are also called forearm crutches. They don't go up in your armpit area. These also can be used just one or both, so unilateral or bilateral. These are typically used for people who are going to be using crutches long term. The nice thing is I can be walking through, when they fit appropriately, I could be walking through, let's say, the grocery store, and I need to pick something up off the shelf, and I can let go of this, and if it's fit correctly, it'll go with my forearm and not fall over like it just did. So, for example, if I have a patient who has maybe a very low spinal cord injury or something called spina bifida, and they have some paralysis of their lower extremities but can do some sort of modified walking, this can be very helpful. I've seen individuals that have a lower extremity amputation that are very, very agile on these. So they take a little bit to get used to, but you can actually get moving pretty quickly on them once you do. So we have a variety of those. As far as the regular walkers go here, this is a front-wheeled walker, an FWW. This is a standard walker, so no wheels. This walker on the posterior legs has skis, which make it very easy to transition between floor surfaces. So when you assemble the ski on there, you want the lip to be forward so that as it goes from carpet to floor, hard floor or flooring to carpet, it just does a smooth transition. Walker skis are always going to be a safer alternative to putting tennis balls on the back of walkers. People will put tennis balls because their rubber posts wear out, or their plastic ones wear out. Tennis balls are cheap, slide them on there, but they're also extremely unsafe. When I was in PT school, I reviewed malpractice cases for walker balls or tennis balls on walkers, and it's ridiculous the millions of dollars every year that are paid out because of tennis balls. So avoid the tennis balls, please. Use walker skis or just replace the caps. This walker here has a platform attachment. Platform attachments are very handy if the person is unable to bear weight through their wrist and hand. They do need to be able to bear weight through their elbow and shoulder, but if I had a wrist fracture and I needed to use a walker because I also broke my ankle, let's say, I could use this to still use a walker. I think I about covered them all there. Yes. All right, so what I'm going to have you do is you're going to work together as a class, and you're going to take and line up from most stable to least stable devices, okay? Go ahead, and then we'll check it off. Okay. So let's start at least stable. What do we got? Single point cane to our quad canes, so narrow, wide base. Those are about equal, so that's good, good, good. So this here, is this included? Or was that just sitting there?
What, the wheelchair?
Yeah.
Yeah, that's your mid stable.
Okay. Yes, but we're not going to use it as a gait assisted device. So yes, it is, but that's perfectly fine. So you could then just put the parallel bars down here. Okay, so rolling walker versus non-rolling walker. There's always kind of toss up as to what is more stable, because this is more mobile. We don't have to pick it up, but it rolls. However, with the standard walker, it does not move, but in order for us to move, we have a period of unsupported as we push it forward. So it's always kind of like the which one, and it depends on how you look at it. So good job. Okay, what we're going to do now is we're going to look at fit of assistive devices. So can I have a patient, please? Someone just have a seat there for me. So we're going to go through each device. I'm going to talk about the fit and how we would fit a patient. Whenever we work with individuals that have assistive devices, we want to make sure we are having their assistive device fit them properly. So sometimes it's something that they've had prior and they bring it in and you're like, okay, we're going to just resize that for you. Sometimes it's fitting them to a new device and just ensuring that it's a proper fit. Each device has general properties for fit that will kind of go across all the devices. Some things are slightly different. We never want to fit a patient for a device by having them stand up and stand there unsupported completely as we do the fit. So oftentimes what you'll do is you'll start to fit the device while the patient is sitting. So you ask them how tall they are. get a general idea of where something needs to be, have them stand up, check it, see if it needs to be raised or lowered, have them sit down, and then raise or lower it. So I would never want to have her stand up, say, oh, this is too short, take it away from her, let her stand there as I fiddle with the device, because that's just a fall risk. Sorry, keep this on you here. Okay, so when we fit a cane, we want the cane, we're going to hold it on opposite of the weak leg. So let's say it's her right leg, so she's going to hold it in her left hand. You want the cane to be to the side and slightly in front of, about 6 inches in each direction in front of the individual. What we're looking for is about a 20 to 30 degree bend in the elbow. Another really nice way to see if it's high enough is if the arm is just placed by the side, not with the cane by our side. Cane in the right position, but place the arm by the side. You want the cane to hit about the wrist crease. So this is about pretty good, if not maybe just a tad too short for me. I'd actually probably bump it up. So how tall are you? 5'7". Okay, so I know you're a little bit taller than me. So I'm gonna start with that. Okay, go ahead and scoot forward. Actually, let me put you in a wheelchair so we can practice getting out of the wheelchair as well as fitting. So because my patient is in the wheelchair and is going to be standing, I'm going to put the brakes on. I'm going to get the wheels out of the way. Okay, go ahead and have a seat. All right, so you're going to scooch forward in the chair. Now, when you stand up, every assist device is slightly different. If the patient is safe to hold the cane and then push off from this armrest, this is fine. If they need both hands to push off, they can keep it in their hand, but also kind of hold there you go, and push off that way. When I'm helping my patient stand, just like we talked about over there, I'm going to be to the side and slightly behind, and I'm going to be on their weak side. So what I'm going to have you do is you're going to lean forward, nose over toes, and stand up on 3. 1, 2, 3. Okay, and I like the placement, so slightly ahead and to the side. I'm going to just have you drop your hand beside. Yep, and so, oh, it fits really great, wonderful. But let's say it was too tall or too short. Okay, go ahead and grab a hold. You're going to reach back for your chair and slowly sit down. So I sit her down, then I readjust, never in standing, okay? That's this one. For the quad cane, same setup. The only nice thing about this is that it stays upright so they can focus on putting their hands on the chair. So again, I went the flat side toward them. So let's say I had to go onto her opposite side because her opposite leg was weak. I would spin it around. All right, you're going to scooch forward in your chair. You're going to lean forward, nose over toes, push up into standing. And she had her hand on the cane, which is completely fine. But if she was to need the assistance, she could push from the chair as well and then grab the cane. You'll notice that my hand was on the gait belt. My hand has not left her. If I let go of my patient, it's unsafe, and during a competency, it's an immediate failure. Okay? So as I'm looking to see the fit, I'm still holding on to her, so if she was to lose her balance, I can help her. So I'm going to actually bring this forward slightly, and just bring your wrist on the side there. Good. So that fits great. Step back till you feel the chair. Reach back with your hand, and have a seat. Okay. Hemi walker. Good. Holds itself up. Nice. Same thing. Lean forward, nose over toes, push from the chair, grab the walker. Now, with this one, we're going to have the back post slightly to the side and in front. So you want the walker to be slightly in front of the patient, not directly beside them. Go ahead and grab hold of it there. And so that looks pretty good to me. And then if it needed raised or lowered, I'd have her sit down, raise all 4 legs, lower all 4 legs. Okay, go ahead and reach back. so that takes care of canes. Crutches. We did box 7. When we look at crutches, the aluminum crutches have height ranges. So like this is 5'1" to 5'9". It's a good place to start, but I can guarantee you, if you set it up for what your height is, it will not be a perfect fit for you. When we assess heights for crutches, we always do overall height first, so floor to armpit. We then, once that has been correctly set, we change the arm height, so for the handle. With this, we always want, again, forward and to the side about 6 inches at a diagonal from your foot. And then what you're looking for is 4 fingers between the top of the crutch and the armpit. So this is a little bit low for me. I never want to be too high because, again, that can have damage to the nerves that run through that area. But if it's too low, it actually really significantly decreases the stability of the device. So again, I would do overall height, and then once that is set correctly, then I'm going to look at the arm length and see, does that hit appropriately? So this one would be fine. If it wasn't, I would have to move it up or down, okay? So I'm just gonna set this for me, and then I'm gonna know it's gonna be too short for you. Now, with crutches, we're going to have the person use them both together as they go to stand up. If they are non-weight bearing, we need to make sure they maintain non-weight bearing through the whole process. So I'm going to say that your right leg is non-weight bearing, you broke your ankle, okay? So I'm going to give you your crutches on the left side, and you're going to put your hands this way through them. You're going to push off of here, and as we go to stand up, you need to hold that foot up off the floor, okay? Scooch forward in the chair for me. All right, and go ahead and stand up. Now, keep that foot up off the floor and bring one crutch around. I'm going to see, okay, this is too short here. I don't really care about this height right here because it's going to change once I change this. I don't need to step around and look at that one because it's the same height. So go ahead and bring your crutches back around to the one side. And through it, reach back and sit down, keeping your foot up. Good. So then I know. Oops. Reassess. So there's also sets of crutches that go from like 4 foot something to 5'1", and then 5'10" to 6'6" or something. So you always want to make sure you have like a rounded out right size. All right, so same thing, keeping that foot non-weight bearing, scooch forward and stand up. Bring the crutch over. Okay. All right, so that looks pretty good. She has a slight bend here. Go ahead and just put your arm off to the side. Hits perfectly. If it wouldn't, I would just move these. Okay, go ahead and bring them back around. Reach back and sit down. Now, some crutches have kind of the same, up here they have a very similar thing to this to move. These ones are not as much fun, so you have to take the wing nut off, take the bolt out of the way, move it up or down wherever you need it, line it all back up. And you'll notice here, if you turn, so right now it's sticking out, but if you turn it, it'll go in. It just has, you have to line it up correctly. You want it to be as tight as possible. And then put the wing nut back on. That's regular crutches. Loft strand crutches, very similar. Overall height first. These you can put on either side. So you're just going to put your forearm through there. You do not have to hold onto this part though. You can still push off the chair, so just let it rotate out of the way. And you're going to push off and go ahead and stand up. Okay, So, similar placement to regular crutches. What I'm looking for is that this part does not go up over the elbow. You want it to be an inch or two below the elbow. You also want this handle to be high enough. So, the overall height is going to control the handle height. This part has its own on the side here. So what I'm looking for is there enough bend in the elbow with her right now? And I'm going to say no, I'd actually like to see that a little bit higher. So go ahead and reach back for your chair. Down. And then I will look to see the cuff height. There. Again, you can just look by the handle and kind of want to rotate it out of the way. There we go. Alright, so now I have a little bit more bend. This is still below her elbow, so that's fine. Okay? Go ahead and reach back and have a seat. Alright. There's your crutches. Alright, now for the walker. Rollator walker or standard walker or rolling walker, all are going to be the same. We already talked about how we don't want to have the patient pull up on the walker when they go into standing. When we measure for the walker, their feet need to be near the back posts. So go ahead and push from the chair, stand up, and grab a hold of your walker. So her feet are near the back post, so I know it's positioned correctly. I have her just drop her hand to the side. I see that it is too short. Go ahead and reach back, sit down. I'm going to flip the walker over. I'm going to make the walker tall. You have to make sure you move all 4 feet. Now, you'll get in the habit of wanting to count the holes. However, when you're dealing with a rolling walker, it will not always line up exactly like if you're on hole 4 here, that it would be hole 4 there. Because of the wheels add a slight difference in height. You want to make sure it is level. You don't want it to be tipped forward or tipped backwards. Alright, push off your chair. Okay, good. Now drop your hand to the side. Much better. Okay? And have a seat. So then the only other thing, with the rollator walker, it's a slightly different. You're not moving anything down here. I mean, you can if you need to, but that's for the seat height if you move down there. The handle height is right here. And so you would just change it there. So the ones that are on the bottom, change the seat height. Okay. And so then the only other thing here is your Alright, so when we deal with one of these, we're going to see if the walker itself is tall enough first before we do anything with this. So it's actually a little tall. Go ahead and reach back. Pop it down and I can. Through there, and then we're looking to see how this height is. So we want it to be about a 90-degree angle, so this is a little bit low. Go ahead and reach back, and then you just loosen all of these. And make it taller. And then they can be on their way. Okay?